So thank you everyone for coming today. I was quite heartened to see large audience, and I was also heartened to see some of my slides being presented by Richard and Tom in advance. So I've had to conjure up some new slides very quickly. So you'll just have to apologize for their slightly undercooked appearance. So I'll just say for the record that I've had a number of declarations of interest. The only relevant one here really is that many of you here in the audience will know is the CogStack related ones, which I build a lot of infrastructure, but we receive a lot of funds from research charities, the technology sector, life sciences to build a lot of the work that some of you in the audience are involved in. I'm just going to, I know this is about AI and we have to have this kind of necessary things. And I know Joe and others earlier in the session have talked about data. And I'd like to kind of re-highlight again, although everyone's talking about AI is in every newspaper article, the AI is the top of the pyramid. And if you try to build a pyramid from the top, you're going to discover that it's not really going to be a very tall pyramid. What you need is the foundations. And the foundations, a lot of the foundations in the NHS and in the research institutions are data related and physical infrastructure and workflows in organizations. So a lot of this work on AI, although there is a lot of interest to do AI, most of the AI work that many people in the audience will know is actually at the next tier down at the data level or even lower down in the infrastructure. So many of the architects and engineers who build a lot, rack up all the compute and storage and such, all that has to happen as well. And so if we chase the top of the pyramid too early, we won't fix the problems at the bottom. And a lot of my time in the last decade working on CogStack and lots of things across King's College Hospital and St. Thomas's is about trying to address the layer just beneath the data and the infrastructure. And I've tried to kind of change my conversation to a more of an analogy, because this is perhaps more suited for a less technical audience, but I thought it's very helpful to explain. Because everyone talks about data, but data means the different things to different people. And lots of people talk about EHRs and EHRs as though they're a single kind of thing and that everyone knows what it means. But we have to think about what an EHR is meant to be and draw analogies to what human society have handled things before. So the EHR is actually a very large library. It's just that the library isn't of necessarily of books, or each book is about a patient, and it's not stored as a book. It's stored as pages, individual pages, and the pages may or may not be on the same shelves, may or may not be bound together by the same patient and such. And this shelving system and this binding mechanism is what some EHR data scientists and such will call a data model or a schema. And many EHRs that exist, big ones, small ones, they all have a schema. And some of these schemas are custom designed, many of them are proprietary, but these schemas are not always compatible to each other. And that's one of the issues that we face today, because many people built these schemas and shelving systems a decade ago, 2 decades ago. And it's like this bookshelf, really. Would you organize your bookshelf by color like this person has? That's offensive to some people, but it's also very pleasing to others. Whereas some people organize them by topic, some people organize them by authors. And so this is a matter. What we discover is that organization is a matter of taste. And the library that we're dealing with, the EHR, is a lending library. It's not a library that we all keep at our home, that we kind of stack up and we admire from a distance. This is a library that is a working library where people take books out, put books back in, take out pages, put pages back in, and write into it. And this is done by thousands of people every day, every second. And what this means is that you need a very efficient shelving system and a very efficient librarian. If you don't have that, you get this. And that's what we've got after 20 years. But how did we do it before? How did the traditional libraries used to handle this. So perhaps for those pre-millennials like myself, you will remember this. On the inside of your books that you borrow. This thing is called an index card. This index card is to allow you to find the book. The finding of the book, the index meaning pointing, is to allow you to track where the book is, who holds it, what the topic is about, and such. And these books were filled manually by librarians for the last century before electronic libraries. And they kept these index cards. There's one copy in the book and one copy here. So this is at Bletchley Park. Actually, they had an index room just for keeping the index cards in little drawers, and this was how they used to find a record. And the information in these cards were what we would call nowadays called structured data or structured codes. So it'll be the author name, the publication date. For us, it would be hospital ID, patient name, and such. But this is to allow us to find the patient. But we'll only be able to find based on, let's say, the author. We'll be able to find based on the hospital number or the age of the patient or date of birth or gender. And so the health records that we built now are just analogs of that. And these health record systems are now use an indexing system. And the indexing systems are based on the identifiers or the dates of birth, dates of death, dates of events, dates of encounters, date of appointments, all that sort of stuff. And this is to allow us to find it. But you can only find things which are in the index. If, let's say, you wanted to find something that's not in the index card, then it's quite hard unless you already have it in your head. And so that's kind of the problem that current EHR systems face. Certainly, before we built CogStack and such, the only way to find something is through looking at the coded form of the information in the index. And so it requires people to use common codes, everyone to agree on the same code. And getting lots of people to agree on the same code is hard because, as I described, it's a matter of taste. So the index also fails when the people write in the books, which unfortunately doctors do a lot of. And let's say if you wrote in the margins of the book here like this, you'll never find this until someone stumbles on it. And that's what's happening right now in healthcare, because we don't find it because it's not indexed. It's written in the margins, and that's the text, the free text. The only way to find it is if we use traditional EHRs, is that when I write in the margin, I also write on an index card that the person has asthma or salbutamol and write the code out. And I'm not going to remember that. And so I don't do that, and lots of people don't do that. And so it's just not trackable. And we know all this kind of free text stuff is all unstructured. And as we saw this morning, the index doesn't handle structured data very well. It can't find the unstructured data, and most of the unstructured data is just unused because it's not findable. And we are now in a new era where I used to have iceberg slides all the time until it was nicked this morning. But I've had to find another one on the internet, and essentially the point really is that everyone's begun to realize that now. But here, the Maudsley discovered that nearly 2 decades ago, and surrounding it, we discovered this very quickly. And to understand how and problems around data, we need to think a little bit about how the data is generated. So one solution is to make people just code the data. Every time we write in the margin, we have to write in the index card. And that's what NHS hospitals force junior doctors to do. Or not just junior doctors, senior doctors, nurses, health professionals, physios, everyone, you have to kind of write into the Word document, and at the same time, you've got to code it into the index, and then that goes into the EHR data, which to be indexed. There's all this other kind of data, all these other unstructured forms, all the multimodal data, all the really, really exciting stuff that will change healthcare in the future. All that also has to be done. And then we hire loads of little people down here to manually read them and filter them into codes. And the people at the top, those are the clinical domain experts, and those are the expensive people. And the people down here perhaps are not necessarily as expensive, but there are lots of them. and they have to read. They spend their time reading and putting it into codes and tables. And this is how most healthcare systems work now, even in the US, here, Europe. And this is a huge manual process. So is there a better way of using these? And the only way to find them is finding the index down here. And that most of the stuff out there never travels down there. And so therefore, you can only find what is coded down here. And because there's a bottleneck, you end up not finding anything. So is there a better way than using indexes? And that this layer is this bit here. Now, I'm not saying that the bit up there is not useful as well, but when I had to face the problem 10 years ago, we had that bit there, which was a tiny amount, and that bit there, which was a huge amount, and everyone thought was not reachable. And all that's in natural language, and all that we are dealing with today. The next layer up, we will address it in multimodal AI and in the next generation of what we can build. But this first bottleneck we were addressing 5 years ago, and we were addressing today. And I'm not going to labor on this because you've seen this before, because we have now a variety of language models which can convert, that can handle this step. And so this bottleneck no longer needs to be a bottleneck. Then, and so we can use that. We can add humans to AI there to support the humans to do this process. And then this bottleneck is solved. And then we can go up to the next bottleneck once we solve this bottleneck. And up there's all these kind of really, really cool stuff, which obviously we see the next generation arriving, and all that information needs the semantic context, the meaning to be added, and the meaning is on this middle layer as well. And so we'd be very excited and to see all this stuff. And so that's kind of my little attempt at producing slides in half an hour. But essentially, I'm just going to, there are a number of other people presenting, and a lot of them are working on projects on specific topics. And these topics obviously will be discussed further. But I suppose one of the kind of other things to add is I'm just going to add a little question kind of at the end, really, because we will have in a Q&A, but there's something to stew on. Why don't we just kind of shove all of it into a big LLM and be done with it? And then let it do all the work, and then we wouldn't. We don't. Let's not deal with this bit. Let's not deal with this. Let's just shove it all in, and then maybe we'll just invent fusion power or something for us. Well, we shall discuss that. Perhaps keep it in your mind, and we can discuss it later. Not sure. I need to naturally introduce Jess, but Jess is a very, very probably a global expert on health data and ethical use of data. She worked with Ben Goldacre's review, drafting a lot of the initial view on open safely and the use of federated data. So Jess, please go ahead.
Great. Can you see, hang on, can you see this? Can people see this? Hello.
It's just a white screen.
Okay, I'm just going to present without slides. I'll just, you just can have my face instead. It's probably easier. So I think the purpose of me talking now, before you hear all about the exciting things that people are working on in the field of AI in medicine, I think I'm just going to do a quick sort of 10 minutes on why getting AI to actually work in the healthcare system is potentially a little bit more complicated than people sometimes think it is, and why we have what is increasingly called the implementation gap, where there is an enormous amount of work happening in the research environment, an enormous amount of models being developed that are extremely successful when they are done in a sort of lab environment, but they do not necessarily make the leap into the frontline care. There are a number of statistics that are showing that this is happening. For example, risk prediction models, the last count that between only about 10% of the risk prediction models that are deployed in the healthcare system in the UK, and it's very similar numbers in the US, are actually using anything to do with AI and ML. And of the overarching proportion of algorithms, that AI, ML algorithms that are deployed or sort of developed in a research environment, only between 2 and 5% ever make it to actually being deployed in the real world. Those numbers are probably slightly different for image recognition, but definitely for anything that's using EHR data, the numbers of sort of success is quite low. And the reasons for this are sort of the most simple way of saying that the reasons for this is it's to do with complexity. So we have an enormous sort of machine of knowing how to do translational medicine for things like drugs and other medical devices, where the complexity of the implementation is relatively bounded. We know how to develop to generate good quality evidence. We know what the infrastructure requirements are. People are used to prescribing drugs. They are used to using things like blood pressure cuffs. Where we are starting to see things fall down with AI is that sort of boundedness, and the contextual infrastructure is missing. And so first of all, from a condition perspective, we are trying to take the healthcare system, which is used to using specific tests for specific conditions, where we know if you deploy this test and if you deploy this drug, then you are going to treat this one specific thing and get this specific outcome. With AI, because it is increasingly perceived as being a general purpose technology, this is especially what is happening with the LLMs, that sort of logic of one problem for one condition and then one solution is broken down. And instead, we are trying to predict and prevent a whole range of conditions through the use of one particular technology. But there are a number of issues with that. For example, we don't necessarily know what the long-term outcome is, and we don't know how to deploy these things in terms of the overarching care pathway. If we are predicting that somebody is going to develop a condition in 5-10 years' time, how do you follow that up? What do you do? Whose responsibility is it to make sure that things are being acted on in time? The second thing is the technology itself. So lots of healthcare systems, and this is particularly pronounced in the NHS, which digitized actually relatively early. So people moved to electronic health records in the 90s, and we started to sort of see the use of IT being perceived as being a benefit to care from about 1975 onwards. But that means that there's an enormous amount of legacy infrastructure. So people may have, anyone who's worked in the NHS or been to the NHS will have seen, we have a lot of wards in the NHS where it's one computer on wheels and nothing is very interoperable. There are up to 17 different electronic health record systems used inside hospitals, none of which talk to each other properly. The way in which we format things into electronic health records is often very difficult. And so it is extremely difficult to get that entire pipeline from accessing data to developing on the data to building a model to then deploying it in the real world, because at each stage of those chains, you're very vulnerable to mistakes in the actual infrastructure. And whilst the places that develop these algorithms are often perfect, they have perfect research environment, they know exactly what needs to happen, then that information or that infrastructure is not available once it gets actually to the hospital and to the patient. A really classic example of this would be a predictive model that is trying to use multiple variables, and the prediction is very, very high. The predictive accuracy is very high when the model has access to all of those variables. And then once it is deployed inside an environment, it turns out that at least 2 or 3 of those variables, whether it be, I don't know, a boring one like blood pressure, is not actually recorded or not accessible in real time inside the hospital environment, and then that sees the decline in the performance of the model. The next thing is the value proposition. So people often try to talk about, how do I sell my service into the NHS? How do I sell AI into the NHS or into a healthcare system? Rather than asking, what is it that a healthcare system wants to buy? So the current quality of the evidence that AI works and that it is safe and effective and that it delivers on outcomes rather than on statistical accuracy is currently very poor. There have been a number of systematic reviews that show this, but just to sort of give a picture of the overarching landscape of this, in the US, the FDA, which is the US equivalent of the MHRA, have approved over 900 medical devices that are using AI. So AI as software and software as a medical device. The number of clinical trials that have been done that are registered for using clinical trial as where AI is the intervention is less than a third of that. So there is a very significant gap between the number of solutions, AI solutions that are on the market, and the number that have been tested in the way that the clinical system, the healthcare systems are used to. There is very few clinical trials happening for reasons that are to do with the fact that developers do not necessarily know that they need to do them, and the fact that clinical trials are designed for static interventions. So they're designed for things like drugs or devices which don't change. That is fundamentally altered with the use of AI and machine learning, where we want the thing to be developing and changing over time because that is its real benefit. So what are we testing? Are we testing version 1? Are you testing version 1.5? What happens when it transitions? Do we need to go back through a different clinical trial? And also, what is the baseline against which we are monitoring? Often people try and say, oh, this is better than the clinician, but that's quite often a poor comparison. It's a poor test. For one reason being, there are multiple, but one that is a clear example of why this is that algorithms, as you've just heard from the presentation before, have access to actually a relatively narrow range of information. It's often structured information that's inside an electronic health record, and it's primarily quantitative information. So things like stuff that can be turned into a SNOMED code, that's like a symptom or a prescription. It doesn't include the wider contextual information, or the sort of what we would call the semantic information about the patient. So things like body language, what do they say? Are they acting like themselves? It's quite rare that a patient would come into a clinic and say, these are my exact symptoms. And this is exactly how they are presenting, and they have gone on for this long. It is much more likely that people will come in and say things like, I don't feel very well, I'm a bit down, or my child is not acting like themselves. Now, what happens is that when we test algorithm versus clinician, the algorithm often performs better than the clinician when the clinician only has access to the same information that the algorithm has. As soon as you give the clinician the information that they normally have, so you don't restrict the amount of information that they have access to, the performance of the clinician actually goes up. So it becomes a non-fair test, especially once we start including things like what type of clinician, what level of experience are we expecting them to have, what are the other environmental conditions that are happening. And then we have to start thinking of next about that is the adopters and the willingness. So the way in which stuff is often framed is either this is going to replace the role of particular clinical roles, or it's going to augment them and give them help back give them time back, or we will give you more time to work with your patient, because all of this other stuff is going to be taken care of by the AI. The thing is, there's no guarantee that it will give them back more time. There is equal likelihood that if you are improving the efficiency in one way, that the hospital or the care system will just come back and say that means you need to now see twice as many patients as you were seeing before. But also there is very limited research done on the human-computer interaction side of clinicians and AI. Now, we don't know, that means that we don't have a great amount of evidence or sort of understanding of what happens when the clinician is interacting with the algorithm and how that changes their perception. There are some sort of generic concepts. The ones that people are most familiar with be like automation bias. So this is the idea that people are very fallible to believing that the computer is always right and will override their decision that they had initially made. So for example, they'll make a diagnosis and then override their diagnosis if the algorithm gives them a contradiction one. There was recently a test done on this where clinicians were told that they were interacting with AI. Some of them were given deliberately false outputs from the AI, so it was deliberately wrong, and still more than 70% of the clinicians changed their decision. The other sort of generic concept that we see arriving in this space is alert fatigue. So how much should we be notifying clinicians of things like predictions, of things like declining, and when in the pipeline of the sort of cognitive workflow should that happen in order to make a complete impact? And then the last thing is that we don't know how to present the information in a way that is mostly interpretable. There is a great amount of work happening in XAI, which is explainable AI. That's the sort of concept that we explain what's happening under the hood inside the algorithm. That's quite different to interpretability, which is the sort of cognitive processes that is happening once a clinician has a piece of information. And so we don't actually necessarily know that there is a one-to-one relationship between an increased amount of information and an increased improvement in an outcome in the patient, because of this sort of complexity in the human-computer interaction. Everything I've just said, by the way, and where I've used the word clinician, is the same if you are presenting that information direct to a patient. And in fact, it is worsened because a patient does not necessarily have the same level of e-health literacy. Then the sort of last two bits of complexity are to do with the organisation in which these things are embedded, but also more to do with the external context. So AI will ultimately end up being regulated. It has to be regulated as a software, as a medical device. But those laws are changing drastically, but they are changing extremely slowly. They are not really fit for purpose. The risk stratification, for example, of software as a medical device largely assumes that is not necessarily the software that is doing the form of intervention. It is assuming that there is not a great amount of agency in the software. AI has a significant amount of agency. It is being used to make a decision. So that's not really accounted for. And as I said before, we don't necessarily know how to deal with this problem of the thing that's learning in real time. And then that means that we don't know how to deal with the fact that actually you need to do a significant amount of what's called post-market surveillance, which is monitoring the performance of the algorithm over time. We know how to do that with drugs in terms of the fact that we have the yellow card scheme in the UK, which is where doctors will report if people have a negative outcome from a drug, and over time they'll see if there are any trends in that. But doing that with an algorithm is very difficult because we don't necessarily know where the problem has arisen. It might be that there is data set drift. It might be that there is population drift. It might be coming from the human-computer interaction. So how you go in and fix that is extremely difficult. So we have regulation coming from software as a medical device. That will incur things like cost. It's also a bit of a dampener at the moment because people are sort of a bit nervous about developing things and when they know that the regulation is likely to change, and adopters like clinical environments, hospitals, etc., are a bit nervous to adopt when they don't necessarily know the clarity in terms of the legal position. The same is happening with data protection law. So remember that triangle that you've just seen. Data protection law is changing drastically in the UK, in the EU, and indeed in the US. And there are complexities in that. So, for example, House typically divides data use or the legal use of data into three, which is direct care research or service analytics, and you're supposed to use your legal basis by defining one of those. AI is typically collapsing and doing all of those three things at once. It's being used in direct care. It's learning in real time, which means that research is still happening, and it is being used to inform care pathways, which is sort of service analytics. So that's changing. Then there are the ethics and governance aspects of what is happening. So do we know that patients are going to feel happy with the use of AI in their care? Do we need to do consent? Do we need to tell them when it is happening? How does explainability work from a patient perspective? What about things like privacy and surveillance? And what does it mean that we are now telling people that they are not being diagnosed on their physical self, they are being diagnosed based on their data self? And so what happens when we get to a point where a patient is saying, I don't feel well, but an algorithm is telling them that they feel fine? These are all complexities that we don't necessarily know how to deal with. And the risk of that is that you get chilling effects. So we deploy something, there is a negative backlash. This is what has happened with projects like Care.Data, for example, in the UK, and then you see a massive freeze in the willingness to use. So these are really just a quick overview of why getting AI to work in medicine and in the healthcare system at scale is more complicated than just buying an algorithm off the shelf that some clever academics in institutions like Yale have developed in their research lab inside a laptop. And so this is just a context setting. So as you go on in this session to hear about all of the exciting developments, to also remember things like what infrastructure is required. Is the data quality good? I haven't touched on data quality because I know you've heard a lot about that already. Is it regulated? Is it socially acceptable? Do clinicians want it? What's the value for money? What's the evidence of efficacy? So just always have those questions in the back of your mind whilst you are being presented with all of the many exciting opportunities, and then also think about how potentially we could overcome those hurdles.
Well, hello, everyone. I mean, a hard talk to follow in a way, because I guess I'm trying to present a slightly more positive view. I'm not a computer scientist. I'm not a data person. I am a clinician. And where I came from, I'm a psychiatrist. And where I came from this was, firstly, was a very simple frustration, was working in the south of Lambeth, looking after 200 people in a team for psychosis, where we basically cut back and back and back, and we discharged everyone that we could possibly discharge without it being too risky. And so there we had our 200 people with psychosis, and there were hundreds of people trying to get in. And we simply didn't know where everyone was. And that was incredibly difficult, because you're sitting there as a psychiatrist in the south of Lambeth thinking, well, where are all my patients? Where does my responsibility begin and end? And so to some extent, this project came out of that. Some of the things that Jess was talking about, I really hear them. And James, I mean, if that's what he does in slides in 5 minutes, I hate to think. I've been using these slides for ages. But so the other thing I was trying to think of, like, what can we do with what we've got? Because there's lots of stuff going on in London and around the world about trying to merge data sets and put everything together. But I just wanted to know, what could we do with the data we have as one secondary care mental health provider? And we have quite a lot of data. I mean, we have data on 420,000 people who are currently alive. So that's not including those who have died. And as James said, I mean, they're brilliant slides because they show you what it's like. It's essentially this massive filing system. And in psychiatry, a lot of that is free text. So structured data is almost useless. I mean, it's got its uses, but it's almost useless because people don't like filling it in. And so it's poorly filled in. So if you can't get to the unstructured data, you're again in a great difficulty as a clinician, because you're faced with, even within one patient, thousands and thousands of lines of text. So even something like a medication review, like what medication has this person been on and has it helped them, that could take you days of work. You know, so that, you know, we talk about very, very highfalutin AI, but, you know, really simple stuff. How do you curate the notes, both for an individual and for groups of individuals and for populations, in such a way that helps clinicians provide direct care? And I take the point about the legal issue. And there is a question now in my mind. I'm good friends with Nicola Byrne, who's the National Data Guardian, and I'm actually the Caldicott Guardian at SLAM. So I worry about these things. And there is a question you might ask: what parts of this that I'm showing you is direct care, and what part is service provision? And say, you know, as Jess was talking about, where you may have different legal underpinnings. But from my point as that clinician in South Lambeth, I think all of this to some extent is direct care, because I have to think, how many patients are beyond my team with psychosis who I might be responsible for? Because take the murder recently in Nottingham, where the man murdered 3 people. Do you remember, all over the news? He had been discharged because he didn't turn up. So mental health services had said, well, we're not responsible for him anymore. But now they're clearly being told, we're all being told by NHS England, you are responsible. So you need to know. So the first thing we did, so I think there are 3 levels. When you try and apply, so by population health management, what I mean, which is the title I gave to my talk, Clinical Informatics for Population Health Management. For me, population health management is, as a clinician, how do I manage my population? That could be as a GP, it could be as a psychiatrist, a cardiologist, it could be whatever. Okay, so when we first looked at our data, we found there were 20,000 people with schizophrenia-like conditions. I don't think anyone had ever looked at that before in terms of from a clinical point of view. They might have looked at it from a research point of view through CRIS, our anonymized data stuff, but they hadn't turned it back to clinical purpose. But what we also found was 3/4 of those patients had been discharged. So 15,000 patients have been discharged to their GPs with the most severe mental disorders, with no follow-up and no consideration. So that's a very real clinical issue that clinical informatics can help us use to provide direct care, even in collaboration. So, for example, you're turning up to the GP and you're saying, okay, well, I know there are 80 people under your surgery with a diagnosis of schizophrenia. I think 20 of them are currently under our care, but what's happening with the other 60? When they left us, they were on this medication, they had these physical health problems, obesity, diabetes. Have you seen them? Are they still taking their medication? Are they, these kind of things allow you then to work collaboratively. So even just organizing, curating your own data into groups, into populations helps you. So I'm just going to show you the way that we've curated data. So there is AI involved in this because we have natural language processing at the heart of this. We're basically searching the text to develop entities. A lot of these have been defined by the researchers. They've been validated by the researchers. We've looked at them again in a clinical setting. So to give you one example, medication, a very simple one. Is it accurate if you search the text for medication? Well, we found it was about 96 to 97% accurate. Well, that's better, we found, than an individual doing them themselves. So you going through, scanning through all the lines, olanzapine, risperidone, you put on, you'll miss quite a few because there's thousands of lines. You click on a button using natural language processing, and in a moment you get a list. So it's very, very simple, but what a difference that makes. Our pharmacists now use this to do all of their medication reviews. So that's transformed care. It has saved huge amounts of money just by a simple application of AI and natural language processing to searching the text to generate a list, which then allows you to do more clever things with that. And we can talk about those. So very quickly, how much have I been talking already? 6 minutes. Okay. So you said 12 to 15. All right. So 3 levels: macro, meso, micro. I think that's population health management. Okay. Macro, meso, micro. So and academics now talk about this. When we started this was just came out of what do we need clinically? Okay. Well, at the macro level, so that's the population as far as I'm concerned. So this is a map of the population. So this is the population of people in their first 3 years of psychosis. How do we know that? Because we have teams where people are they're called early intervention teams, where people in the first years of their psychosis. So why is our data good for psychosis? Our data is good for psychosis. That's not me. Data is good for psychosis because psychosis is severe. It's very hard to have a psychotic illness and not become known to local mental health services. If this was depression or anxiety, obviously we'd have much greater problems, and we might also have greater concerns. Like, would you like it if you could see, say, on your road, all the people on antidepressants, for example? And also the question of scale. Now we're looking at LSOA level, so 1,500 people, 650 households roughly. We're not going more in than that because, we do have these concerns about, what level of scale is okay. But anyway, this is showing you the people with psychosis in South London under our early intervention teams. So i.e. it's a proxy measure of incidence. So it's showing you where new cases are emerging. Now, the other thing in terms of health policy is there's a recognition that doctors can't do it all. So we have this thing called integrated care. And integrated care, as you probably know, ICBs, all of this, it's about coordinating the system so that health, social care, the voluntary sector, etc., communities, individuals themselves are all working in some kind of coordinated way to achieve better outcomes. Okay, we do this across healthcare, but if you think in terms of psychiatry, so if you know that, say, on particular estates or particular areas, which often, of course, track socioeconomic problems, poverty, etc., have a higher incidence of psychosis, so new cases, when you're thinking about where to put your resources, so they may be medical resources or they could be pre-medical resources. So imagine, say, one of these estates highlighted here, if you were to put in, say, I don't know, support around, say, families, cannabis reduction, employment, whatever else, you could imagine that you could start to shift the dial on the flow of new patients into the system. Okay, because if you think of Wes Streeting, what was it about? Reactive crisis care to prevention. Analog to digital. That's what we're trying to do here. Okay, at the meso level, So now I'm thinking of about 200 people. You could, as Jess was saying, think about pathways. Now, is that direct care? Well, I was the clinical director for psychosis. So I was responsible for providing care to the 20,000 people with psychosis. I don't think the clinical director before me even knew there were 20,000 people, let alone that 15,000 had been discharged. But if you think of a pathway of those 20,000 people, how many of them have been given the NICE standards for the treatment of psychosis? And if they have been given them, what outcomes have been achieved? Surely we should be able to see that. We should be able to see in an area, have we equitably given all of the NICE guidelines of care to this entire population, and what outcomes have we achieved on the back of that? Are we achieving the outcomes we'd expect? But this is just 200 people. So one of our meso platforms, if you want, is a team-based one. So it doesn't look quite like this, but you've basically got lots of little panels, and a lot of them are drawing on natural language processing. So they might show you who hasn't had their physical health checked. Remember, physical health in serious mental illness is a big government sort of drive, big NHS drive. So you might want to know, well, who hasn't had their blood pressure checked? Who's got a high BMI? Who's borderline diabetes? Well, you can drag all that together. You'd be surprised perhaps we're not doing this already, but we're really not. You know, we have, as I say, just these filing systems, as James was saying. But at a team level, if you can just see on a platform, well, look, of our 200 people, these are the 6 who we're worried about their blood pressure, because it's drawing out of the text of their notes. Now, of course, there's limitations because they may have got their blood pressure checked by the GP and you haven't seen that. So obviously, we'd like to share data, but we do with what we can. You also can gather together their risk. You can say, well, these are the people who are at risk of violence in our team. These are the people who are at risk of suicide. These are the people who've been under our team for more than 3 years who aren't very complex. Perhaps we should be thinking of discharging them. So that kind of curation at a team level, rather than just an Excel document, which is what people literally use, makes a radical difference. But look at this one, because I love this scatter plot. Each one of these is a patient in one team. This is live. It's not live now, but when I took this off the system, this was live clinical data updated every day. Okay, so each color is a patient. So each dot is a patient. Each color is a care coordinator. So you imagine each care coordinator's got about 20 patients. The y-axis is presentations to A&E and emergency services. The x-axis is people in beds. Now, if you were trying to work out as a team leader how to organize your resources, your pharmacist, your psychologist, your social worker, if you were slightly higher in the system, is this still direct care? I don't know. But within the system of how many more resources should I put into that team, you'd surely be concerned about the people who are outliers, turning up in A&E a lot. How can you move these dots down to the bottom? These people, not dots, people. How can you support the care coordinators who are struggling with their patients? And you can imagine a much more efficient, both in terms of cost, but also in terms of clinical outcomes and you know, patient care, better patient care, by putting your resources in a much more structured and efficient and targeted way at that meso level. Then the other thing is using outcomes. Okay, I've got to speed up. I need a few more slides. So at this other meso level, this is about using outcomes. Now, at the top, the red bars are dissatisfaction. And each one of the bars is like an area. This is the dialogue scale we use as a primary clinical outcome measure, but also for dialogue, because in dialogue with your care coordinator, you work out what you're worried about, basically. So I think it's number 3 is employment. Another one is medication. You know, they're all various ones. Employment. So now what we have is we have IPS, employment support, is again, it's another big drive to get people with serious mental illness into employment. So we have workers doing that. Well, this, rather than wait for referrals, they can work out who is dissatisfied within the team, within the service, outreach to them to provide them the employment support. Also using the maps as they're doing, they can see which areas of the borough, for example, people are dissatisfied or are lacking employment. They can also, what they're doing, we had a talk yesterday from Holly Brearley, who's doing that. She links up with employers in those areas where there's both high incidence and high unemployment and high dissatisfaction with employment, starts to bring them together to try and ensure that when she's walking around the local areas with patients she's looking after, she's linking them up with employers that she's built links with in that local area. I mean, it's extremely clever. I mean, what an incredible thing to be offering within a health system, and using data to underpin that activity. And then also she's looking at, I can bounce over the next slide when it comes. She looks at inequities, like, are the Black patients missing out, or are the women missing out, and then she can reach out to the teams and say, by the way, you're not capturing enough of this particular group, so you can start to address inequities. And then this other one at the bottom, well, that's showing different types of therapies. These are the 7,000 people with bipolar. Remember, it was 20,000 with non-affective psychosis, 7,000 with bipolar, and these are before and after measures with different kinds of psychotherapy, CBT, group therapy, family therapy, art therapy, and population sizes. So you can begin to track your effectiveness. So then at the micro level, so the last level, macro, medium, micro, this is one patient. So here, again, this is a very early iteration. It's going to be better than this. But basically the idea is that at the top, you're looking at service use. So the green is the person in the community, meeting community. Is it mauve? Or whatever that is, pink. Those are admissions. So you imagine if you start to chart under that the medication the person was on, or whether they had psychological therapy, or whether they were in stable accommodation, you can start to begin to see which interventions are keeping that particular person well and in the community. So then you can, at an individual level, with a click of a button, be much more personalized in your care. And then likewise at the bottom with physical health, again, I just cannot understand why we don't do this. This is just showing the person's BMI, their weight going up over time. This is showing their marker for diabetes, HbA1c, changing over time. A lot of the medications we prescribe increase weight, but all we do is do these points of structured data. We never graph them together. So once you put all these together synchronously, you can start to see, well, which of our interventions are helping, which are hurting, which would be right for this person going forward? What haven't they had? And then finally, inequity. So I talked about inequity in terms of employment. You can see there are massive inequities. The people we put in the wards, so these are admissions. The medications we treat people with. So the Black population is much more likely to be prescribed long-acting injections, much less likely to be prescribed clozapine, which is a second-line treatment for schizophrenia. Again, without curating the notes in this way, we would have no way of knowing this stuff. And a lot of this is drawing on, as I say, natural language processing, which is a form of AI. And likewise at the bottom here, access to psychological therapy, whether people remain in therapy. So you can use this both to identify people who haven't accessed therapy, whether people are being offered it, whether they remain in it. And if you remember from one of the last slides, whether they achieved a good outcome because of it. So I think this kind of curation of the notes underpinned by AI, long before you get to these predictive algorithms of risk, which I agree with Jess, have all kinds of problems and need to be thought about very carefully, we can do an awful lot. So this is the optimistic version of the things that one can do in this space. And it's been a huge thing in mental health.
Thank you, and thanks for the invitation to speak today, James. I'm not a clinician, I'm a doctor of philosophy, as it were. Essentially come to you as a data scientist today. Like Rob before me, I'm an optimist eternally, obviously, but particularly with this project. Sorry. Thank you. So just first slide, just quick overview of what the background and the challenges for the project was. So the background is this is an epilepsy project. 1% of any population on the whole suffers epilepsy. For those who don't quite know what epilepsy is in very simple terms, sort of excess sort of electricity going to the brain causes seizures as a result. Most seizures only last for a few seconds. The longest one's usually up to about a minute. But of those 1% of the population that does suffer from epilepsy, around about a third, 30%, do not respond to anti-seizure medication. So they're called refractory. And they're essentially the patients that we're focused on for this particular project. So the underlying hypothesis, as it were, as we've started out, is that if we can use AI, particularly machine learning and other tools to data at scale, the machines, etc., can actually discern previously unrecognised predictors, meaning essentially anti-seizure medications of refractory epilepsy. In other words, applying the machines at scale to see whether they can identify drugs that either reduce the seizures for refractory patients or actually prevent seizures all up. So the solution is we'd sort of originally posited, but we do have success. I won't go into sort of specific details, but by applying these machines to the records at scale, we have identified a handful of drugs that we think actually do help these patients there. Thanks to our two co-funders, there's Epilepsy Research Institute of the UK and an Italian private pharmaceutical company called Angelini Pharma. And in the interests of full disclosure too, Angelini have the European distribution rights for one of the 31 drugs we're looking at, which is cenobamate. So the team is here. James, of course, to my right, whom you know, and Anthony Sheck, who was here this morning, but I think has sort of disappeared after lunchtime. Mark Richardson's my other key boss in association with James. Mark's head of School of Neuroscience, and his career has essentially been in epilepsy. So he's sort of the principal clinician. The grunt work or day-to-day work is essentially done by Shichao Fang and myself. So what's new? Really sort of three categories, as it were, which is sort of new is distinct from sort of new-ish. The first one, we believe the data set size is probably the biggest epilepsy real-world data set in the world. If it's not the one, it's certainly one of the biggest. So just sort of headline figures there with King's College Hospital. We've got about 52,000 electronic health records and about a bit under 6,000 patients. Similarly, Guy's and St Thomas's, which we've ingested in the project over the last few months, 33,000 records and a bit under 5,000 patients. So that gives you a total of 85,000 EHRs and almost a bit over 10,500 patients. What I want to do is sort of clarify that what we've actually found through the data, and fortunately, we found very recently that the patterns that we're looking at with key data in KCH patients mirrors that of GSTT. And in particular, roughly about 85% of the patients are effectively of no use to us because they don't change their drug medication and their seizure status doesn't really change. So in other words, it's the 15% we're looking at. So in other words, that 10,500 really reduces to, in broad figures, roughly about 1,000 patients that are of interest to us. Why have we taken that duration? Start of 2013 to September 2023. September 2023 with both hospital trusts when they started using Epic. That's why we stopped there. We started at 2013. The advice we've got is prior to that, you start getting sort of handwritten notes, etc., which is too hard to analyse for our purposes. The second bucket of new, as I call it, is applying generative LLM, large language models. This is new. I'll have a bit more to say on that. But what we're using them for is to extract the key epilepsy data that we need from these highly unstructured electronic health records. And the third bucket of it, which we're in the sort of phase now, is applying machine learning in particular to build predictive models about what anti-seizure medications work best for these refractory patients, and also to use not only machine learning but a whole bunch of standard data science tools for, if you like, historical analysis with the data sets that we've actually got. Challenges, of which there was many, but these ones are sort of the primary ones. The records that we're using are mostly doctors' and nurses' letters for outpatient visits. I can't stress enough that these are unstructured free texts. The language is quite often ambiguous and vague, especially when it's coming from the clinicians, less so from the nurses, ironically. And what struck me as a non-clinician, but as a patient probably primarily, or occasional patients, I should say, that the clinicians are highly inconsistent often with entering basic epilepsy data in these outpatient reports. In particular, the anti-seizure medication, we wanted to know what was the current medication the patient was taking. You'd be surprised how many times that's not entered. And also too, whether or not the patient's suffering seizures. And if they are, what the frequency is. if they're not, whether they're seizure-free, if they have been seizure-free, for how long, 6 months, 12 months, or whatever. So a lot of that elementary data is not actually there a lot of the time. In a perfect world, you'd have some sort of epilepsy template that after an outpatient visit, the doctors or the nurses would be following in loose firms, but that doesn't exist. That's one of our key recommendations to come out of this project. And so this is a thematic that's come out of the conference thus far today, a real cultural problem that really needs to be addressed. Another issue for us was obviously this information is confidential. So what we did, we played it safe and just used open source LLMs in that sense, in particular Meta's Llama models. In terms of the large language models themselves, I think probably everyone's aware of this term hallucinations. We prefer to call them confabulations because they kind of get mixed up with their memory rather than sort of, taking magic mushrooms equivalents for AI. But we had to spend a lot of time in what I call sort of tempering the enthusiasm of the language models. There is an anthropomorphic, I won't go into detail, side of language models. You do actually have to give them characterization role plays as part of the prompt engineering, which is the second dot part. In our case, we said you are actually professional neuroscience. You're talking to other neuroscientists, answer these questions for us. One of the most memorable hallucinations for me, or confabulations, I was testing it on one particular sort of patient data, and the LLM actually not only gave a very detailed clinical analysis of the patient's condition, but actually was prescribing specific drugs. And from my sort of punter's aspect, it looked quite plausible, actually. In terms of performance and evaluation, that's another thing too. All this is very, very new. So when we're trying to apply it specifically to epilepsy, you use conventional things like accuracy. That's not that great, but F1 scores with recall and precision, AUC graphs, etc., etc. But I think there's an ongoing debate. How do we actually really sort of drill down into how we actually should be properly evaluating performance of these things? A big issue for us too was getting annotations done amongst the team and broader team, and how to get proper inter-annotation agreement for that. That's another big thing, particularly in the LLM and NLP community. They're discrete audiences, but how do you do this with full transparency and defendability too? Big debate, particularly over the last 2 years. And last but not least, rapid revolution. It's often described as a cliche, but it's true. There's effectively an arms race in terms of AI generally, particularly with LLMs. Just one thing we came across, no sooner we started adapting Llama 2 at the month after it came out in July last year. We sort of had that running, for our purposes around about February, March this year. And of course, April, Llama 3 comes out. So you just sort of always, you're like the little mouse on the treadmill, running forward and never getting a breath of fresh air. These are sort of the key categories. The ones in red, I'm slightly colorblind. I think that's red, not orange. They're our primary focus. You can see there, starting up at midday, sort of epilepsy type, and then seizure type at 1 o'clock, coming down to kind of roughly 5 p.m. You're getting current epilepsy medication. Then around 9 p.m. seizure frequency, and 10 o'clock seizure freedom. The other ones I won't go into. You can see them there in some non-red color. Can't quite work out what that is, but they're the other things we were looking at as well. They're the 31 epilepsy drugs. I won't go through them, but the rationale here is that their medications are available to prescribe in the UK during those 10, 11 years that I mentioned. We're also capturing brand names and derivatives through standard sort of NLP coding there as well. One of the things I should point out is that there's some drugs in particular like lamotrigine, levetiracetam, they're in the middle under the rails there. They're sort of the most used drugs by far. So we've got sort of a problem not only with the imbalanced data set that I talked about before, but even in terms of distributions of drugs that we've got to take into account. Diagrams, this just give you a feel or a flavour for kind of how the overall architecture works from a modelling point of view. I can't stress enough, this is like a cartoon. As my builder said when we were trying to do renovations a couple of years ago, architects' plans are just cartoons for builders, and similarly in this forum today. But hopefully this will give you a sense of what we did. So if you start up at the top left, we've got the 2 hospital trust database, and to great credit with James and everyone else who's worked on CogStack. Without CogStack, this project would not exist. We used CogStack to extract the EHRs that we wanted through the search terms that Thomas was talking about earlier today, to do with epilepsy, and then sort of drill down a bit more detail. So it's both GST and KCH. So we ended up with these doctors and nurses letters, bit of pre-processing there. In particular, we're dealing only with adults rather than minors for various reasons. I won't go into that. Then in our instances, we found it Meta's Llama 2 with a timer in. Remember, just chronologically, it was early this year we were doing that work. That worked best for us for a whole range of reasons. That ends up giving us the key epilepsy data that was extracted with that sort of clock slide that I showed before. We then have some algorithms that we bespoke ones we wrote to transpose those into sort of data frames, whereas rather as epilepsy data per electronic health record goes to key epilepsy data per patient. And then from that, with all our machine learning and other sort of tools at disposable, and we're still going through this process to identify what we think is 2 or 3 ASMs, anti-seizure medications in particular, that we think are really good for refractory patients. Final slide there, if anyone's interested. Just a paper we brought out a couple of months ago that came off the back of the ACL, Association for Computational Linguistics, their biomedical NLP workshop, which was a terrific workshop. If you just go for my staff profile on KCL, there's a link to that. The mnemonic, as I always say, think of the toothpaste and knock off the C, put on an H in Holgate. So with that, thank you very much.
Good afternoon, everyone. My name is Antonio. I'm one of the consultant cardiologists. I'm an obstetric physician between King's Denmark Hill and St. Thomas's, and I'm a researcher at KCL. So today I'd like to talk to you about how we're using some of the tools that have been described today to improve the care of patients with inherited cardiovascular conditions. So I'll start by telling you what inherited cardiovascular conditions are. Is a very big umbrella to include a bunch of conditions that individually are rare and affect the cardiovascular system. So we have from one end channelopathy. Oh, sorry, it's kind of displaying slightly weird, but channelopathy, so ion channel problems that affect the way electricity is conduction in the heart, associated with sudden cardiac death and arrhythmias. Then we have a bunch of cardiomyopathy, so heart and muscle diseases such as hypertrophic cardiomyopathy, and I show you there an MRI of someone with very advanced hypertrophic, so very thick heart, and I hope you can spot that the heart muscle is very, very thick. Also dilated cardiomyopathy, also known as heart failure, so a heart muscle that is weak, dilated, baggy, the most common cause for heart transplantation. And at the end, I show you a CT scan of someone with an aortopathy, so a disease of the main vessel of the body, the aorta, where patients are prone to have dilatation and unfortunately dissection. So if you can see in the middle of the vessel, there's some lines there. That's a tear, so that's a dissection, is a life-threatening condition. So each of these conditions are rare. So channelopathies 1 in 2,000, HCM 1 in 400, DCM 1 in 250, but collectively they are not so rare. I show you here some data from a charity in South London, so CRY, Cardiac Risk in the Young. They've set out to screen young, healthy adults, so school-age children involved in sports at a kind of higher level. They've so far screened over 300,000 asymptomatic young adults, and it's quite striking, the findings. About 1 in 300 of these young individuals had the diagnosis of an inherited life-threatening cardiac condition. 1 in 100 had features that require follow-up. And the main reason why they do this is because every week in the UK, about 12 young adults with no symptoms and no signs of cardiac disease die of one of these conditions. I have done some previous research in this field, mainly using UK Biobank, so this big research data set of 500,000, I was going to say middle-aged adults, so between the age of 40 and now their late 70s. It was funnier when I wrote it and not 1 week away from turning 40. So these are patients from community-based, from GP health records. We know that they do not have a diagnosis of, in this case, hypertrophic cardiomyopathy. They've been genotyped or genetic sequencing. So we found about 1 in 400 carried a variant that predisposes to this disease. Does that matter? That was the question. Yes. So if you look at their MRIs, they have some features of the disease, so increased wall thickness, remodeling, increased trabeculations. But much more importantly than that, their outcomes are different. So the patients that carry the variants, the red lines, have more sudden deaths, strokes, arrhythmias, etc. So even in asymptomatic people that made it to middle age and over, it's associated with poor outcomes. So we're missing a lot of patients with inherited cardiac conditions. We're really looking after the patients with very extreme, very advanced disease where they have symptoms, and we're missing all the rest. So I can't tell you about all inherited cardiac conditions, so I'll today focus mainly on one as an exemplar, so hypertrophic cardiomyopathy, the very thick hearts. How do colleagues in my specialty diagnose this disease? Well, it's not as easy, so we need lots of types of data. So we need history, we need physical examination, and we need family history. A very important risk factor is what's the disease expression in the family. We need lots of multimodal imaging, so we need data from echocardiograms, from MRIs, from CT scans. We need ECGs, so we need the electrical patterns from 12-lead ECGs. And if we see a combination of these features that could be consistent with a diagnosis, then we consider genetic testing. And that is very helpful for risk stratification, because we know some genes are associated with worse disease than others, but very importantly for family screening, because these conditions run in families. And if we find the familial variant, we can go find that variant in the rest of the family. And how do I risk stratify? So there's this very helpful risk calculators, and all the clinicians in the room are used to use calculators. I think there's a couple of thousand now. They do help. They do enhance bedside clinical care. So this is the state-of-the-art calculator to predict the risk of a patient with HCM of dying in the next 5 years. And you'll see there's a few tabular points, so how old they are, how thick is the heart muscle, and importantly, family history of sudden cardiac death, yes or no, have they had an arrhythmia, so that non-sustained VT bit, and have they fainted for a reason that can be not explained. So this is the gold standard. This is what we use in this country and across the world, every patient I see every week. But if we step back, we're talking about big data, we're talking about these millions of data points. The study where this came from analyzed 3,600 patients, and of which 198 died. So the state-of-the-art risk stratifications is on this small data set. And we now try to use it in other populations, and in a time where there's a lot more data available, we're actually bidding it all and just collecting these 3 or 4 data sets, data points. And we do that because it's trying to kind of meet human limitations. I see a patient every 15 minutes. I could not manually incorporate all these other features. And you can see here, there's no information about genetics because again, that would be too complicated. The genetics of inherited cardiac conditions are fairly simple. The vast majority are autosomal dominant conditions. And I just saw a clinical geneticist in the corner, so hopefully I won't get into trouble. So where a single variant can be inherited either from father or mother, and having that a single variant is enough to cause disease. So they can be fairly simple. And you can see here, when we find a patient with a given condition, we'll have to screen patients up and down the family tree. But the genetics of inherited cardiac conditions can be a lot more complicated than that. Again, most of this information we bin in day-to-day practice because there are lots and lots of genes that can cause different cardiac diseases. They're interrelated. Different genes are associated with different outcomes, some much more aggressive than others. But again, we kind of know that at an academic level, but it's really difficult to translate when we have a patient in your 15-minute clinic slot. Regarding genetics, a very helpful advance of NHS England was setting out very clear guidance on who to genetically test, so very strict criteria. So through the NHS Genomic Test Directory, I show you here for HCM. So again, if you have wall thickness in your heart over 15 millimeters that cannot be explained by other reasons, we can go ahead and do genetic testing. And we should do family screening. And I show you there one of the letters we send. So every time we diagnose someone, we give them a letter and ask them to pass to all their first-degree relatives. So we just found a patient, and then we have 5 or 6 more immediately. So going back to where are these lost ICC patients? Many have never had tests. They're just in the community asymptomatic, but there are lost opportunities. So most NHS patients have had the right tests to find some of these conditions, but they just had it in the wrong settings. So very many of us have had ECGs because they're going to have a dental extraction or your gallbladder out. It's seen by the anaesthetist or the surgeon. Is there any reason not to operate? No. So that's it. That's the last time that data set is going to be looked at. Patients have tests like CT scans, again, for gallstones or for COVID. If there's a finding of a dilated aorta, unless there's something terribly, terribly wrong that goes in the report, the doctor that was looking after them for COVID is satisfied with their bit of information. Everything else gets binned. So patients have had the right testings. It's just in the wrong setting to be interpreted. So a lot of these features are overlooked and ignored, and actually not even make it to medical records, GP, or the patient. And this is particularly important for ICC because we know if we find these patients early, we can re-stratify them, we can change their lifestyle, we can guide them through which occupations they should or should not have, and we can do early interventions and treatments. And importantly, we can screen their family. So we can find other people to benefit from this care. The vast majority, nearly all genetic testing that is performed on the NHS is performed by specialists or people that have an interest in genetic disease. So all the patients that have the features of genetic diseases under other healthcare professionals do not get genetic testing. And finally, we also have the opportunity to prevent these conditions being passed on to the next generation. So for example, if we find someone that is a carrier of one of these genes, we can have a chat about reproductive options and pre-implantation genetic testing. Another big problem in ICCs and receiving advanced care, such as genetic care, is to do with biases in healthcare. So this is some research done here at King's by one of our colleagues, Professor McCarthy. It's a completely different data set. So it's patients that are put forward to have TAVI, so a keyhole procedure to open up their aortic valve. So for treatment for severe aortic stenosis. There's no evidence that there's ethnic differences in the prevalence of the condition, but white European people in South London are 8 times more likely to have this treatment. So there are systemic biases, and we don't know, they could be either patients coming forward with symptoms or with the healthcare system to put them forward. So these are human biases in the system. So how can AI and LP can help? Well, these tools can be applied at scale, systematically. They can integrate all these very disparate tests wherever they are done. They can make sense of them. They can find correlations that are not obvious to the human eye. And they could be trained not just to identify very specific rules or features, but combinations of these features. They can help overcome human biases, and I know we'll have some chats about this, and this has to be tested. And I think they could be very helpful at bringing patients to specialized care early. So I'll briefly talk you through what we're doing in this field. So this is what I'll talk you through in the next few minutes, are projects funded by the Genomic AI Network and the MRC. So these are the colleagues that are actually doing all the work that I'm taking credit for. We're using CogStack, again, electronic health records, millions of them, both at King's, GSCT, UCL. We're using NLP to translate this large amount of unstructured clinical data, so clinic notes, ward round entries, but also the reports from radiology, from echocardiograms, etc. We're using a type of clinical terminology, so the human phenotype ontology, which is very helpful at very specifically characterizing certain features or symptoms so that we can link them up more easily with genomics. So that all this data is much more helpful to speed up genomic analysis or interpretation. These are the pilot conditions we're studying. I won't bore you, but hypertrophic cardiomyopathy, aortopathies, familial hypercholesterolemia, which is a condition of high cholesterol, and dilated cardiomyopathy. I'll tell you the first Vanguard project that is the most advanced. So we started in April. Is led by Alex Steng, who's here with us. So the goal is finding patients with aortic dissection. According to the National Genomic Test Directory, all these patients should be offered genetic testing if this happens early in life, so below the age of 60, if there's no other reasons for it. So what Alex has done is labeled quite a few dozens of words and expressions that all exemplify aortic dissection. He's then deployed it across CT scans taken for over many years at St. Thomas's and in the future at King's. He's identified a list of quite a few hundred patients that have met this criteria. And we're now at the point where within a few weeks, we're inviting the first few patients into a clinic by a clinical geneticist who will confirm or not the diagnosis, offer genetic testing, and we'll be able to then report back on what's the acceptability and what's the yield of an AI tool to identify these patients and bring them to the attention of a specialist. Going back to risk stratification, I show you here our state-of-the-art risk stratification tool. I put some dots there for someone with mild disease, a 20-year-old with not very thick heart, family history of someone that died, but they've never had arrhythmia. So if I see them this Monday, I do this. I put the risk as low, about 4%, which is below the threshold at which I recommend a defibrillator. I order some tests for the next year. And because this is the way we work in the NHS, I'll book him a fixed appointment 12 months from now while I'll review data again. He has a Holter in the meantime, so everything is the same, but in the meantime, we found non-sustained ventricular tachycardia, so an arrhythmia. That in the text is expressed as broad complex tachycardia, BCT, non-sustained VT, ventricular run, so lots and lots of expressions. So it's difficult to write a rule unless there's natural language processing involved. The finding of that in a monitor increases risk of dying within the next 5 years to nearly 9%, at which case he's a candidate to have a defibrillator as soon as possible inserted to prevent sudden cardiac death. So the next time I'll do this calculator will be a year from now. There's really no obvious tool to highlight it to me in the meantime. I'm near the end. So can we do better? So I leave that task to Ronnie and Ed, who are PhDs in this field. They are basically developing tools to identify these patients early and in real time, to develop tools of dynamically real-time risk stratify these patients. And by integrating all this data in thousands of patients over decades, we're hoping to find new predictive models that can beat the current state of the art by integrating much more data. And Ed in particular is very keen to find patients for clinical trials because, again, it's very difficult to identify them at present. And I'll leave the rest for another day. Thank you very much.
That's it. I'm just going to invite whoever who has enough time to come up to the front so we can have a little bit of a conversation, because you've had 4 back-to-back talks, and I don't know if we can get
are you? I think Jess has dialed off already.
Okay,
so,
that's fine. Okay,
just people.
Yeah. All right. So I'm just going to start because I know Rob, you may have to. That's okay. And
I know you've got a lot, so probably let's kind of finish your question here. I know there was a lot at the beginning of the precedent and optimism about AI, which is it good, is it bad, but what's the net effect? Well, I mean, it's happening whether we like it or not. So, what do you think? Do you think it will have a positive and negative effect on mental health services and our mental health?
Someone who's not particularly good at computers, it's fine. Ended up spending so much time with it. So yeah, I think all of us will be impacted by this stuff. I mean, I think one of the points that Jess made, again, I think it was really important to hold all our feet to the fire, was about the rollout of all these things within the NHS. And the one thing I didn't mention was that what I was showing you was really a proof of concept, which we call Viewer, the visualization and interaction with health with electronic records. And what that has now turned into is something called Lucy. So locating useful clinical information. Got to love an acronym. So Lucy has come out of a 1.5 million grant from the multi-charity to see whether we can roll out Viewer as an NHS supported service. So I think that is really quite a step forward. So all the slides I showed you are being, or all the functionality is being looked at again from the point of view of supporting it as a managed NHS service, which if you think then has to be incredibly robust because, it has to go through all the clinical safety and all of this. But everything I've shown you, as far as I understand, is going to stand up within Lucy, I think next month. So the view at the moment is that this can be safely provided at that level. And as I say, already bits of it are being used. So, for example, they're talking about pharmacists and their medication reviews. We've got a team who's using it to identify people with missing physical health data amongst the SMI population to ensure that they're specifically reached out to complete their physical health data. These team leaders are using it to organise the allocation of resources within teams. I'm definitely starting to use it with individual patients to get an overview within a crisis home treatment team. When you say you've got to review 15 patients in an hour and a half, there's no way you're going to be able to read all their notes. But if you can just curate their notes at a glance, it's incredibly helpful in terms of trying to determine, well, what are the risks here? What's the medication history? What's been done before? What possibly might we do next? So I think that, it's happening and we're using it, and I hope that Lucy will be a success.
Thank you. I guess just going back, obviously it helps the clinical services, these technologies. So obviously there is lots of AI tools now which are just being rolled out. Just like social media was rolled out a decade ago, which are outside of the healthcare sphere. And there's a lot of things in the media recently about the impact on mental health, that kind of thing. There's talk now about AI boyfriends and girlfriends, chatbots, which obviously this is all kind of future talking and stuff, but I just wonder what do you think how that will play out? Do you have any thoughts on that? Being someone,
okay. Well, probably not popular in this room. I think I'm a bit conservative on this point. I was getting a great question there. I'm sure you will be reading Jonathan Haidt, and I know that people say that you shouldn't reduce things down to single factor causality, but obviously Jonathan Haidt's very concerned about the turn towards all things online, all things social media, all things AI. So yes, in terms of mental health, I think it is a concern. As I understand it, the sort of global data is that a lot of this stuff isn't making us healthy. However, what I would say is that as a doctor, rather than thinking in a broader sense, and I'm sure this must be true of other professionals in their fields, the quantity of data you're being asked to synthesize, analyze, and make decisions on is just getting bigger and bigger. And
even as I said, at an individual patient level, sometimes it feels overwhelming, the amount of data you have to, but when you're starting to think of a group, it's completely wrong. So what AI is really doing is a data reduction technique. It's reducing that data down to a level at which you can say something sensible, whether you've got 5 minutes, 10 minutes, or half an hour, which you probably would miss without. So I think at that level, it's good for the sanity of doctors, potentially done in the right way.
Probably not on AI work as already. I mean, you obviously just like some of the other questions, you have struggled against the system to bring innovation to our health system. How do you? Perhaps you want to have some thoughts or comments on how that plays out, or how to make it better.
I'm going to have a psychiatrist next to me. Like most things in research, there's these pendulums that swing from being able to go and proceed quite quickly to now having, I believe, an almost over-regulated and too slow process that is definitely not keeping up with the technology that is being developed. So right now, all the steps of the process are too slow, from obtaining funding, ethics, and then even deployment and contacts. And we do have to find as a community a way to not reinventing the wheel for every single minor app and minor tweak of an algorithm. Even a place like here, we're really at the epicenter of deploying CogStack and natural language processing in our own electronic health records. For example, some of the projects I discussed took about 1.5 years to get ethical approval, and people have done it in epilepsy. I now just want to look at cardiology. Why is it taking so long? So that's something that we should really be very aware. If we want to deliver improvement in care to patients at a pace, we need to do better.
You think on some of the bureaucracy as well, then, haven't you?
Yeah, and I'll avoid AI bots for things and girlfriends. I think a couple of things. Just before I refer back to yesterday, I was lucky enough, or sort of lucked in, or RSVPing to a particular talk yesterday. It ended up being John Jumper, who, of course, the day before won co-won the Nobel Prize for Chemistry. And a couple of things that John pointed out that I thought really pertinent for today, and thanks to Richard Dobson and his organising that talk yesterday. Very humble guy, but he's extremely enthusiastic. A couple of things you mentioned. One was that he was just pointing out that with AlphaFold, it's taken years to develop. A lot of times they're progressing just through intuition, but he kept stressing that it's progress of 1% at a time. It's not like you think of something one morning overnight in the shower and the next day you've got like a 20-50% boost in your development. It's 1%. So in my parlance, it's like a long, hard grind. I think that's it on one hand, but on the other hand too, he was talking about how you actually improve efficiency, and my background, that's a big thought as well. One of the things he pointed out, the difference between industrial or industrialised research, I was the term that he was talking about with Google DeepMind versus academic research that we're actually in. And one of the impediments with academic research are in that we call it a sort of 3, 6, 9, 12 month sort of timeline where you have to get publishing papers out. I think that's more of a North American perspective, but certainly here it's sort of 6 months, 12 months, you can push them out. And he quite correctly pointed out that that's an impediment with the development of the pace of research, particularly overlaying that is you've got this sort of arms race, in inverted commas, of AI tools coming out, which is incredibly difficult just to keep on top of that through reading, but also to experiment, which takes a long time, just 1% increments with the new tools that come out. So that's another thing I think we should all put on the agenda, how to actually improve the efficiency of developing these things within the AI race, the regulatory restraints, the regulatory delay that everyone's talked about today, and so on and so forth. But, big issue.
Opportunity, I guess, but clearly ready. I'm quite loud about it.
Well, then, yeah, all right.
Thank you. I'm not going to put you on the spot, James. but what I will do is jump on the query, the question you asked earlier about why don't we just throw all this into one large LLM and just let it do its business. My question was, and maybe more to you than to the rest of the panel, what's the cutoff point? We've had a lot of wrappers out there with OpenAI APIs on offer. Thinking of Microsoft and Copilot and all these Scribe and ambient voice recognition, even the ability to, essentially interrogate workflows has been touted. What's that cutoff point where customers or care settings are just wasting their time with those LLMs and need to focus more on CogStack or other tools?
Me, my own question for myself. So I would say that throwing all, it is tempting to just throw all the data together, but you still need to organize the data to throw it in. And so a lot of the work at that second tier of the pyramid, we still need to put the data in. One of the advantages of doing it our way right now is that the data has intermediate benefit. As you can see, others have shown for all the things that can be done right now, not waiting for the future. We can deliver benefit to our patients and our system and understanding of the diseases right now. And so a lot of the kind of future thinking is being built by people who have no real idea that we can deliver value now. And if we deliver value now, then we'll bring everyone with us, all the patients with us, the public, they all will see the benefits. We're not building a distant castle. We're delivering value now, and I think that's a big factor in why if we focus at an earlier stage, we get value. Now, perhaps AI will leapfrog all of this, but I would say that it also boils down to the data flows. And so if we organize ourselves with the data, manage estate, improve the pipelines, all that will have great value. And AI, as you say, that there's so many AI models now. Every big tech company or small tech company is producing a new foundation model or wrapper. It's going to be a commodity. It'll be on all your phones. It will be on your glasses. It will be everywhere. And so it's not going to be the AI that's going to be interesting. It's going to be the data. And the data is renewable. You generate it every second. So that I think is much more. That's where I see the future value. But into the short-term value, I think we can implement things now, and we should do that as a catalyst to the next phase, which all the talk I think Jess mentioned as well. All the work around the bias and all the risk, all that can be addressed if we sort our data early.
James, you're running behind. You mind if we maybe take one more?
Yeah, sure. Okay, thanks for keeping. Yes.
One big theme that came out of the presentations we saw was about the source data quality and the need to manually code. So I've pointed out some very low-hanging fruit. I'm a clinician at Guy's. I go in, I watch her write her notes after my consultation, and I'd like to be confident that she's written good notes and she hasn't been ambiguous notes. So Epic could simply very, very easily put a little bit of AI in there. She writes her notes at the end of consultation. She clicks the button and it has a green, amber, or red dot as to whether she's done a good job of writing those notes. Only she needs to see it, but I can guarantee that if that was there, every consultant would write better notes after a few weeks. Okay. Now, why am I doing it that way? Because in a normal business like I run, I look at the work that my staff do, and if they don't write good notes, I discipline them. But that's not going to happen in the NHS. We're going to have to rely on self-discipline, and of course, making it easy. I guarantee that writing good notes is an easy discipline you can teach yourself, and that the AI will help people get green. Thank you.
Any comments on someone who has seen a lot of
Yeah, the only point I was going to make is I agree with you. I think there's a virtuous circle where people start to see that the curation of notes is helping them at these various different levels.
put their resources, including their own resources, more efficiently, then that the incentive is to write the better notes for the better curation. And so I think getting into that virtuous circle is absolutely right.
And it's what in IT called closing the feedback loop. If you don't know you haven't written good notes, you can't get better, can you? So we want to close that feedback loop to make it sure as possible. And at the point of data entry is the right point to do it.
Yeah, I agree. I referred to it, in our presentation. I'd say it's pre-AI, it's pre-machine learning, etc. It's just basic administration. Another thing too that's important about it is it's implicit within the whole day-to-day is that this is all multidisciplinary. That hasn't been explicitly expressed, but AI plus health, but there's a whole bunch of other things as well. There's been many speakers who've talked about their own backgrounds, lawyers and clinicians, etc. But that's a huge deal. And I think in this space, one of the things that attracted me, this space is inherently multidisciplinary in practice as well as sort of theoretical. And so in that sense, this sort of AI health sort of thing can be sort of a flag bearer for this, academically and practically as well. On these sort of things as well, I've been speaking through the King's Institute of AI. They've got some sociologists who are experts in organisation, in the workplace. They look at these things from a very different perspective from what you're talking about, what I've talked about. Those people have got a huge value add. So the more sort of multidisciplinary experts we get involved, the better.
Certainly all these tools are brilliant. The only thing I'd like to add is time. Quality and time are inversely related to each other, and if people are short on time, they'll just ignore the red mark.
I do the trial, they won't.
Okay, right.